So we have a 40-year-old male patient who has recurrent palpitation. Well, he's diagnosed with paroxysmal atrial fibrillation. That's the reason why he's having recurrent, that is paroxysmal. Okay, and echo shows normal left ventricle function and no valvular lesion. He's initiated on medication therapy. 2 weeks later, the patient undergoes a TMT test, treadmill test. The heart rate increases, that is normal. And from 75 to heart rate went to 165. The QRS complex duration increases from 0.09 second to 0.13 second. You know this is normal, and this is a wide QRS complex. Okay, so that means the narrow complex has gone to wide QRS. Which medication is most likely to do this? Well, the answer to this question is Flecainide. C. Okay. Well, the answer to this question is Flecainide. We know very well that Flecainide is a class 1 antiarrhythmic drug. And the class 1 drug, they block sodium channels. And they inhibit the initial depolarization of the phase 0 by blocking the sodium channels. Well, as far as Flecainide and propafenone, they are class 1C antiarrhythmic drugs. And they are not a very commonly used drug, but occasionally they are used for treatment of atrial fibrillation, for maintenance of normal sinus rhythm with a structurally normal heart. If you look into the question again, revisit the question, the echo was done and patient was total normal structure. There was no structural normality in the patient in the question. So we want to use for atrial fibrillation. Remember that in this patient has a recurrent attack of atrial fibrillation, so-called paroxysmal attack of atrial fibrillation. And we want to maintain to normal sinus rhythm, so that's why we prefer to give this drug. But they have the slowest rate of drug binding and dissociation from the sodium channel receptor. Well, under normal circumstances, Flecainide does not cause any significant prolongation of QT or QRS because their binding is for a very, very short period. But when the patient has faster heart rate, like in our case, when the patient was subjected to TMT, where the heart rate increased, in that scenario, drug has less time to dissociate from sodium channels. Okay, and that lead to a higher number of blocked channels. This in turn lead to a progressive decrease in impulse conduction and widening of QRS complex. So that's why in our case the QRS interval went to from 0.09 to 0.013 second, which is a more than normal. Normal QRS interval is less than 0.11 second. So you get a wide QRS complex because of this reason, because they didn't get time to get dissociate from the channels. And this phenomena is known as use dependence. Use dependence. Okay. It's most frequently with class 1C antiarrhythmic drug, less with class 1A, and almost nil with class 1B. The mechanism behind their efficacy, and this is also the mechanism behind their efficacy in supraventricular tachycardia, for which we are using this to maintain the normal sinus rhythm. As far as amlodipine is concerned, it is a dihydropyridine calcium channel blocking, and it does not exhibit use dependent. Okay, it does not, and it does not lead to any prolonged QRS or QT interval. Again repeating, this is dihydropyridine calcium channel blocker. Digoxin, it inhibits sodium potassium ATPase, sodium potassium dependent ATPase, okay, pump, and it increases intracellular sodium. And this intracellular sodium, which is excess, will be exchanged via calcium, via sodium calcium exchange. This results in increased entry of calcium. Intracellular calcium will increase, and this calcium will bound to the contractile protein in the myocyte, and that lead to myocardial contraction. And that's why they have a positive ionotropic effect. They also increase the vagal tone and slow conduction through the AV node. The AV node conduction is slowed down because of vagal activity. Now that's why they can exhibit different type of arrhythmia, bradyarrhythmia because of AV nodal blockage. They can even enhance automaticity also, delayed after depolarization. And all they lead to ventricular ectopy and tachyarrhythmias, more common in older and underlying cardiac condition. Remember, digoxin can lead to, this themselves can lead to different type, all types of heart block and all types of arrhythmias can occur in digoxin toxicity. So now I have a question for you, write down the answer. So as I just mentioned, digoxin can lead to all types of arrhythmias and block, but there are two notable exceptions which do not happen. Write down the answer in your copy, which are the two exceptions which do not happen in digoxin toxicity. Well, the answer is class 2B block and atrial flutter. So these two, one block, 2B block and atrial flutter are the two things which do not happen in digoxin toxicity. Now, as far as metoprolol is concerned, it is a beta blocker and inhibits sympathetic activity, which leads to decreased rate of impulse generation, and that's the reason they lead to decreased heart rate, or they cause bradycardia. They increase refractory period of AV node. That's why we use in various types of arrhythmias. They do not prolong QRS interval. Now, verapamil is a non-dihydropyridine calcium channel blocker. Just to remind you, amlodipine was dihydropyridine, and this is a non-dihydropyridine calcium channel blocker. And they have an antiarrhythmic property, especially with verapamil and diltiazem, and verapamil has more than the diltiazem. They also show use dependence. They also just like class 1C drug. But what's the difference? Difference is there's no change in QRS complex. Remember, in our question, the patient has prolonged QRS interval from 0.09 to 1.13. So that's why, although they have use dependent quality, but QRS interval is not changed by these drugs, especially verapamil. So as far as verapamil, they cause the increase in calcium channel blockade and they increase ventricular activation. They cause prolongation of refractory period of AV node, leading to increased PR interval. But most important is they cause increased ventricular activation. That's the one thing that is really matter of worry. As I told you, they do not increase QRS duration. Golden line to remember: use dependent refers to enhanced pharmacological effect of a drug during faster heart rate, and it is seen with class 1C drug and class 4, especially non-dihydropyridine calcium channel blocker like verapamil and diltiazem. Class 1C agent cause prolonged progressive decrease in impulse conduction and faster heart rate, leading to increase in the QRS complex duration also. And this quality is not there with a drug like verapamil and diltiazem. So we got a 65-year-old man and he come to you due to heart palpitation for last 2 weeks. His past medical history is significant for coronary artery disease, hypertension, type 2 diabetes, and ECG demonstrate irregular rhythm and irregular pulse also. That itself indicate atrial fibrillation, because there is no other condition where we get irregular pulse. So we are very clear about at least we are dealing with the case of atrial fibrillation. Well, the question is most common anatomical site of these original of this patient arrhythmias. Arrhythmia, I have told you, it is atrial fibrillation. The question is about what is the site of origin. And I am sure by now you have done the question, and believe me, this question is done wrong by more than 95% people commit mistake in this question. The right answer may shock some of you. The answer is pulmonary vein. Well, this is the most common wrong answer. This is the second common wrong answer. But why this is the answer, why not others? Let's go into depth of the subject. Well, the correct answer is unbelievable, but you have to believe it, pulmonary veins. Well, this patient has atrial fibrillation that I told you in the after reading the question only. Why? And in fact, it's one of the most common cardiac arrhythmias. Typical presentation are absent P wave replaced by tiny chaotic fibrillatory wave. You can see this ECG. Okay. And irregular. RR interval, you can see this is RR interval, all are irregular. And narrow, but QRS complex is narrow. That is a very, very important point. QRS complex is not wide. This is atrial fibrillation. Now, come the main point. Pulmonary veins, PV, are the most frequent location for the ectopic foci that cause atrial fibrillation. How come? What is so special about it? Well, there are cardiac tissue, so-called myocardial sleeves, which extend into pulmonary vein. I'll show you a picture in the next slide. Now, this sleeve, it functions like a sphincter to reduce reflux of blood into the pulmonary veins during atrial systole. So they prevent the backflow. Okay. Well, look into this. This is the left atrium. This is the pulmonary vein, which is draining into the left ventricle. Now, this particular part is a part of the atrial tissue which extend into pulmonary vein. Well, and it is a site of ectopic focus. Normally, it prevents when atrial systole will happen, when atria will contract. This prevent the backflow. It is not a proper sphincter, but act like a sphincter. So, if I have to draw a diagram for you, this is the pulmonary vein, and some part of these atria, left atrium, extend into this like this, and it's a site of ectopic foci for atrial arrhythmias, and of course it also prevents regurgitation of blood into the pulmonary vein during atrial systole. So we got a concept of sleeve. Now, this tissue has a different electrical property than the surrounding atrial myocyte. We are well aware that in normal cardiac tissue, SA node is the main site of origin and second impulse site is AV node. But now today must be listing something great also, that we have something called cardiac sleeve, which also has a different type of electrical activities. And this is prone to ectopic electrical foci or aberrant conduction. So this can initiate atrial fibrillation. Now let's look into other option, AV nodal bypass tract, which is the most common wrong answer I told you. This is seen in WPW syndrome. So-called SS3 pathway is there, and so-called pre-excitation syndrome. It may develop a recurrent re-entrant loop conduction pattern, or it may also develop atrioventricular re-entrant tachycardia. Two types of things can happen with this. There is a upsloping R wave is slurred, what we call as delta wave. Our characteristic feature, and second thing is PR interval is usually less than 0.12 second. That means short PR interval and delta wave are the classical feature that we see in the patient of WPW syndrome. Look into this. You can see short PR interval, only you can say 0.10 second. Normal PR interval is 0.12 to 0.20 second. It is only 0.01 second, and you are getting a notch in the ascending lumen of R wave, and you can see this slurring is there, and that is so-called delta wave is seen nicely here also. So now we talk about atrioventricular node. It's a re-entrant tachycardia result from a re-entrant circuit formed by two separate conducting pathways, one fast and the other slow, within the AV node. Okay, well, we know the AV node has a maximum refractory period, but sometimes there can be two pathways, and this is characterized by sudden onset and termination, rapid regular rhythm 140 to 250, narrow QRS complex, and absence of well-defined P wave. Why? Because the impulse is getting generated in the AV node, and P wave is formed by the impulse from the atria. So that's why we don't get a well-defined P wave in this type of arrhythmias. Finally, SA node is the normal site of origin of any impulse. The normal atrial discharge rate is 100 to 180, and regular RR interval, normal P wave, QRS complex, that is all like a normal ECG, except the rate is very, very high. Okay. Now, I have a question for you. Write down the answer. How we really calculate heart rate in ECG? Write down the answer. So, how to calculate heart rate? Let us say this is the, okay. We see number of small square between, let us say this is the ECG paper, and 1, 2, 3, 4, 1, 2, 3, 4, and let's have a one wave like this and one wave like this thing. So now if we have to calculate heart rate 1500 divide by number of small square between two R waves, R wave 1, 2, 3, 4, 5. So heart rate in this case will be 300. It's a very simple question, but just to refresh your knowledge, how we calculate heart rate. So the regular RR interval, normal QRS complex. Now this tachycardia can be due to increased sympathetic activity, or this could be due to decreased vagal tone. Both will lead to increase in the heart rate. It could be physiological like exercise. We all know very well that we run and the heart rate increases. Pathological condition like fever, hyperthyroid, they all lead to tachycardia. Now tricuspid annulus, again something lovely thing to discuss. This is a most common cause of atrial flutter, is a re-entrant circuit around the tricuspid annulus. This again a gold medal question not known to most of students. With slowing of the impulse through a region known as cavo-tricuspid isthmus, something unique thing to discuss. Let me show you a picture. Well, in case of atrial flutter, you get classical sawtooth flutter wave. You can see sawtooth flutter waves. Okay. But what is more important is like what I was talking to you regarding cavo-tricuspid isthmus. Okay, and there is a line of block in the cavo-tricuspid isthmus. It is this which generate atrial flutter. You can see like this. Okay, I can make it bigger slide. Look into this. Yeah, I hope it is visible very clearly. Yeah, right. And now let me show you one better picture. Look into this. Focus on this, and same is a bigger diagram. So we are getting systemic venous side of CVTI. We are getting pulmonary side of CVTI, and this is the blockage in between. And this is the focus. And that's what I was showing you like this, which is the line of block in the cavo-tricuspid isthmus. And that generates the atrial flutter. So the golden line to remember, atrial fibrillation is the most common caused by ectopic foci within the pulmonary vein. Point to be noted is the ectopic focus in the pulmonary vein. The most common cause of atrial flutter is a re-entry circuit around the tricuspid annulus, with slowing of the impulse through a region known as cavo-tricuspid isthmus, where the slowing occurs. Well, I hope you liked this session. Just to inform you, we have following courses for you. Smart Medicine. There are 350 hours of pre-recorded video lecture of whole internal medicine. It includes all super specialty and allied subject, covering A to Z, including basic concept about every topic. Second, we have tests and discussion. There are more than 1,000 questions with discussion of the questions, sample question and discussion you saw in this session. Now, third thing is Medicine Simplified, which is a textbook of medicine. Harrison is the ultimate book to read medicine, but it is too vast. Reading one page of Harrison, you need half an hour. To understand, you need 2 hours, but you need only 2 minutes to forget what was written in that page. Then what is the solution? We have Medicine Simplified. It's a textbook of medicine, but so-called mini Harrison. It's a summary of what you need to read from Harrison. The book is available in Amazon also. Now, these 3 things are more than enough for your MD, DNB Medicine and Family Medicine final exam preparation, NEET SS exam preparation. You don't need to read any other book. These 3 are complete in all the aspects. For more detail, you can contact at this number. It's a mobile as well as WhatsApp. And this is my personal email ID. Anybody want to reach to me, you can contact me at this email ID. Thank you very much.